Hello, hi, and welcome back. This is the session on ultrasound. Some students wanted specifically certain images, which they had difficulty. A gallstone, gallbladder is the most common image they will keep for your NEET or your hospital. But I think a few papers had little tougher image spotters on ultrasound. So I did. So they wanted me to do a session on this and we will try our best to clarify certain doubts. So the questions asked were, Mickey Mouse sign is a landmark and safety sign. In fact, I covered this in detail in the session that I did on management and imaging of varicose veins. So the complications of drainage of an intra-abdominal abscess by ultrasound guided. Then the following, there is something known as a contrast in ultrasound, like the way you have contrast in X-rays, contrast in MRI, and contrast in CT, you also have contrast in ultrasound. And what exactly is this target sign? Where does it occur? Let's go through each question one by one. So Mickey Mouse sign is a hallmark of safety in where exactly do you find it? So let's have a look. Is it radiofrequency ablation of the thyroid? I'll talk a little bit about ablation of the thyroid, especially benign nodules. They can ablate it. Not all thyroid nodules need to be operated upon. They can be ablated with radiofrequency waves. So how do you exactly localize them on the ultrasound, and then you give the radiofrequency waves? But there is no Mickey Mouse sign. This is how exactly the thyroid will be butterfly shaped also. This is your trachea. We can even draw it. This is your trachea on ultrasound, and these are the two lobes. So there is no Mickey Mouse sign here. Is it a cilious plexus block? This image is not mine. I've taken it from the net. Let's have a look at the answer. Is it a cilious plexus block? Look at it is also done under ultrasound guidance. You will get the ram horn appearance, see, of the celiac plexus. So this is not the answer. You will get the ram horn appearance. Similarly, this is the schematic diagram, and this is not the right answer. A Doppler has been added to the ultrasound because vessels are very close here. You add a Doppler, you'll know exactly where is your celiac plexus. And you give celiac plexus block in chronic severe abdominal pain. Classic example is in pancreatitis for pain relief. IVC and hepatic veins junction. Let's have a look. This diagram again is from the net. I didn't have a collection, or I could not search one. You find both the IVCs, both the hepatic veins draining into the IVC. Now, this confluence, it has got a very clinical tonation. You can use this in shock. This can be imaged in your epigastrium itself. There will be no bowel gas there. If you want to look at the rest of the IVC, bowel gas will be overlying. But here there will be no bowel gas. So you can measure the diameter of the IVC. And 1.7 centimeter is normal. If it is less than that, that means the preload or the intravascular volume is low. So this is one of the applied significance in shock. It is something known as measuring apart from measuring your CVP, apart from measuring the other blood parameters, blood pressure, the pulse pressure, and mean arterial pressure, you can also look at the IVC directly and look at the pre-volume. There's no question of calculating the pre-volume or the preload. You can look at the volume itself by looking at the IVC. What about the ablation of varicose veins? Yes, ablation of varicose veins. This is very important. Now, this is your right answer. This is the typical Mickey Mouse sign. See, somebody is putting a radio frequency ablation. You need to know where is the junction. You cannot be blindly firing the energy source, because you'll end up either injuring the femoral artery or the femoral vein. Your idea was not that. Your idea was to be only at the junction of the saphenofemoral junction. So if you're going to injure important structures, they are going to thrombose. We don't want that. We want only thrombosis just below the junction or at the junction, and thrombosis of the saphenous vein. So let's have a look why it is called Mickey Mouse sign. You see, this is the femoral artery, and then you have the femoral vein, and you have the femoral, and you have the saphenous vein. Now, one of these structures naturally will pulsate. So you will know that is the artery, and the other one is the saphenous vein, not the femoral vein, saphenous vein. This will be huge. This is the femoral vein. Your femoral artery and your saphenous vein may be the same diameter, but one will pulsate on a real-time ultrasound examination. This is a still picture. So the answer is ablation of varicose veins. You will look for this safety sign, not elsewhere. Here they don't come. It is not called target sign, but you'll be looking for these signs, but they are not called target sign. Now, the other question was, when you do a therapeutic aspiration of an intra-abdominal abscess. Intra-abdominal abscess will form either because a liver abscess or a perforated duodenal ulcer, perforated gastric ulcer, colonic ulcer which has perforated, or your appendicitis. That collection cannot be left in the abdomen. It has to be drained. So the least minimal will be your ultrasound guided drainage. Instead of doing an open surgery with its attendant problems, you can do a minimally invasive with your ultrasound guided aspiration. So what are the complications? You have a whole lot of complications. There can be hemorrhage. Now your abdominal wall muscle can have blood vessels, and that will bleed. Or the abscess wall will be very vascular, it will lead. After all, they are all frail granulation tissue. Rupture of the abscess wall. You can see the wall, here. You see? You can see the wall here. And what will happen? When you put in a needle, you can make a big rent in the wall, and the fluid and the pus inside the abscess cavity will spill over into the peritoneum cavity and cause peritonitis, or a bowel may be injured. That's why you must all the time make sure that between the anterior abdominal wall and the collection, there is no intervening bowel. Perforation, yes, your bowel perforation, none of the above. Whenever complications are asked and written none of the above, never go and tick it. Because no procedure, however minimally invasive, will come without a complication. So straight away you manage to get because it is Excel, you know straight away you got the answer here. So, and I wanted to stress that the incidence is about, in spite of these complications, they are quite rare, and incidence is about 5% only. Now let's look at the video and I will explain. This is the aspiration being done. We can edit when we want. So you can see that it is being localized with the probe. And this is the aspiration being done. Okay. The following agents are used in the contrast material in ultrasound. Now, ultrasound, you can also use contrast. I told in the beginning of the presentation, you can use contrast in ultrasound studies. What does a contrast contain? Lipids, proteins, polysaccharides, or hydrocarbon. Just look at that except. So, contrast will have lipid, protein, polysaccharides. It will not have hydrocarbons. What it will have is perfluorocarbons. This actual perfluorocarbons, you would have seen it in synthetic blood substitutes. They will act just like RBCs, flow like RBCs. So you'll be able to find out better blood flow. Here you can't make out blood flow, but here you can make out there is, in this contrast enhanced, you can make out there is blood flow to this lesion. So you must understand it's not hydrocarbons, but fluorocarbons. Now, target sign, this is a very famous sign, on ultrasound is typical of, let's see the options. You have the options, which is your hydatid disease, intersusception, malrotation, or none of the above. Let's look at the options. Hydatid disease is what you get the water lily sign. This is from my friend Sana Omar. She has sent it to me. It's known as the water lily sign. Now coming to intersusception, let's have a look. This is your target sign. You can see bowel within bowel. You see, this is one bowel and within the other bowels. Bowel within bowel is known as the target sign, like the way you do the bullseye target signs when you use your darts. Is it in malrotation? People tend to confuse the target sign with the malrotation sign. Let's have a look. See, in the malrotation sign, you will have something known as a whirlpool sign. See, it's like a whirlpool. You can see 3-4 layers there. So, in a malrotation, it will be a whirlpool sign, and this is confirmed with your CT. The vein will be wrapping around the artery. Your superior mesenteric vein will wrap around your artery. So this is the malrotation, which is your whirlpool sign. So you must know you must not get confused between malrotation and intersusception. It's target sign, it's whirlpool sign. One more clue. Whenever they give you an ultrasound, they usually give you a little bit of the history. So you're a sort of little, you see, invariably here they will give a young age. They will say red currant jelly is true. Whereas here they might tell an age, they might tell constipation, this, that, but they will not give the word red currant jelly. So you will get clues in the stem itself. Any imaging especially, it's very difficult for a student to be thrown an image and asked what it is. First of all, the student doesn't know where to even go and look in this big image, whether he should stay in this corner or that corner. So they also give you clues so that you know more or less where to narrow down your vision. So that keep in mind. Look into the stem again and again when they are asking you for imaging spotters. Could it be none of the above? So obviously this is not. So the target sign, you find it in intersusception. So the correct answer is intersusception. So we had discussed a few MCQs with some explanation, and I also showed you the other options, what type of imaging they will have. So it is not that we just tick the right answer. No, the other options were also given explanation why they are wrong and what exactly you find in those options. So thank you very much and keep posting your doubts. It's only when you post and bring these questions to me on my Telegram or my YouTube channel, I'm able to make a subsequent reel or a short presentation on this, because I know exactly what these students are looking for. Instead of just talking about ultrasound for a clinician, it will not take you anywhere. But when I make it as an MCQ, I know I've covered quite a bit. But then I also know that I've covered what you wanted particularly in that particular question. So thank you very much. Please keep subscribing, sharing and liking, and also follow my Telegram channel. So once again, thank you.